afternoon, everyone. People kind of load in. Thanks for joining us today. We have a great group of panelists here to kind of help us focus and discussion our mentor hour on simulation outside of high fidelity and procedural-based simulation. So this event was put together by the Simulation Academy Faculty Development Subcommittee. We have a great group of panelists here, and I will let them kind of introduce themselves, as well as kind of how they branched out in simulation. So other than the high fidelity and procedural simulation that we typically think of for EM residents, and kind of the areas that they've branched out to and the niches they've developed. So I will start with Dr. Sara Hock, if you don't mind introducing yourself.
Sure, I can go first. So I'm Sara Hock. I'm at Rush in Chicago. I beyond EM resident, high fidelity simulation and procedures. I've done work in primarily standardized patient-based OSCEs and faculty-focused simulation events. So faculty within the emergency medicine department, critical care, and surgery at our hospital. So that's probably what I'll focus on today, unless that overlaps too much with some of the other panelists, and then I can change gears.
All right, Dr. Bentley.
Hi, everybody. Thanks for being here. I'm Susie Bentley. I am the Director of Simulation at Elmhurst Hospital in Queens, New York. And ways that I've branched out that I'll be focusing on are really using sim for systems assessment, quality improvement, and implementing new spaces, equipment, or processes.
All right, Dr. Lugassi.
Hey everybody, Danny Lugassi, he, him, his. I'm an emergency medicine physician and medical toxicologist at NYU Bellevue. I've been there for 12 or 13 years now. I'm also the medical director of our simulation center, which is a joint partnership of the City University of New York, CUNY, and the NYU Health System. Thanks.
Dr. Koboldt.
Yeah, hi, I'm Tim Cobalt. I'm at the University of Missouri Columbia, and I'm the director of emergency medicine simulation for us. My area of focus is not our standard resident high fidelity simulations, but where I've started to focus more is on bringing virtual reality and augmented reality into our simulation curriculum. And so that's kind of what I'm going to talk about today.
All right, last but certainly not least, Dr. Ahmed.
Thank you. I'm Rami Ahmed. I'm the Simulation Division Chief and Simulation Fellowship Director at Indiana University. I've been in this role here for about 2.5 years. I'm formerly in Ohio for about 10 years, post-fellowship in the Boston area. I've done quite a bit of sim outside of the brick and mortar sim center for EM residents, to include a lot of EMS and tactical stuff, telesimulation, primary care offices, in situs, in a wide variety of environments, even outside of inpatient floors. Done some stuff with medical decision making with NASA, and have even done some communication type simulations on air disclosure, death notification, both in the regular simulated environment and telesimulation environment.
Great, thank you guys so much. And then definitely feel free to ask any questions or make any comments in the chat. I'll be monitoring that to kind of insert them and ask them along the way, or feel free to kind of unmute yourself and ask. We have a small enough group that will make this kind of as interactive as possible. So we can kind of jump in and get started. So we're hoping that you can kind of share with the group some lessons that you've learned kind of branching out from doing these certain niches that you've been doing outside of just the procedural simulation and high fidelity simulation that we traditionally think of with residencies. If there's any kind of things that you've learned along the way, or kind of how you've really branched out and kind of explored those options. Feel free to, whoever wants to start can start.
Well, I guess I can. Sarah, go ahead. Do you want to?
Sure. So I'll start with faculty simulation a little bit, because one of the things that I learned once I did it well for it was a novel thing for a novel group at our institution. Once I did it well for them, I was asked, oh, can you do it for this group and this one and this one? And so first of all, make sure it's something that you truly enjoy if you are starting to branch out on something new and or novel, because you'll probably get asked to do more of it, which I think has been a really positive thing and has gotten me a lot of new connections within the institution. But keep that in mind, that if you start being known for being good at something or doing something that's received well, that you may be asked to do more of it. And I thought it was a good thing, but
Definitely great points, Dr. Ahmed. Did you have some things to add?
Yeah, along those same lines, preparation above and beyond what you would normally expect, especially in an environment where it's sort of not your home field, which would be, the brick and mortar sim center. It really requires quite a bit of extra preparation, especially if you're depending on personnel that you haven't, typically depended on. So much to Dr. Hock's point, when I was in Ohio, much smaller shop than Indiana, there really wasn't a go-to disaster person. And because a lot of the disaster training kind of falls on the sim person, since most of the disaster training is simulated, I kind of became known as the disaster person. And despite my best efforts, I became the disaster day sim guy. And I mean, I think disasters are okay, but it just became this thing that was popular, then became more popular. And next thing you know, you're sort of the disaster guy, even though I didn't really have a desire to do that. Now, that being said, every time you do something, you're kind of putting your, I don't want to say your reputation at stake, but I mean, it's a reflection of the quality that you, wish to push out there, tied with yourself and your team. So you really do have to make sure that you're taking that extra step to do a rehearsal, go through the motions, walk through the logistics, because if you try to get there the morning before, an hour before, it's going to be a suboptimal performance. And it's going to be probably not the kind of quality that you want to associate with yourself.
I think building on that, because that's such great advice, is a little bit of a scope creep, especially in the beginning. If you're starting to get outside of your sim center and even doing in situs or doing big things like Rami does, such as a disaster day, is trying to start small. So not necessarily saying no to things, but really thinking about the low-lying fruit or the highest impact area. And maybe you're not doing it, you're never going to start a disaster sim from start to finish if you've never done them before at your institution. But what are you just doing the first 2 minutes of arrival and then kind of growing from there, I think is good advice that I've grown into over time, with, picking and choosing how we do sim. And I think the flip side, I would say, is also, as you branch out more, being very deliberate about your outcome or what you're hoping to do with the simulation, which is a bit of a framework shift from doing sim purely for education. In resident sim, where you're putting every learner through every sim and the metrics are a lot clearer, or your deliverables a lot clearer. Obviously with systems assessment or things like that, being, just very deliberate in what question you can answer with the simulation if you're doing simulation for something other than purely just education.
Yeah, definitely fantastic points. Dr. Lugassi or Dr. Koboldt, do you have anything else to add?
Not necessarily this discussion, but I apologize to the group. I didn't, in the introduction, kind of mention what I might talk about. I think for me, branching out, and I can just mention it, we can come back to it, thinking about faculty development, which I think is a very different, obstacle as far as just residents who are almost assigned to come to you, or my Tox fellows, where I have kind of a smaller group. Now, I have heard different departments actually have great faculty development simulation programs where faculty are, again, assigned and have blocked off, time for us. We haven't been able to build that in, but we have volunteer faculty simulations. And for me, I wanted to also bring out that I branched out in the last couple of years also in the OSCE world and the standardized patient world, specifically around ED-initiated buprenorphine. I think most of you know it's obviously something that is quite important for our field, but still very underutilized. So I was kind of using faculty development and standardized patient to address kind of behavioral and communication interactive needs, which are, you can't do that without patients. So I kind of stopped there, or come back to that or expand to it, maybe, yeah, wherever you want to go with that, Michelle.
Yeah, feel free to kind of expand upon it. I think it's definitely an interesting topic, in terms of faculty development. How do you, like you said, get the buy-in from your group, from the faculty? How do you kind of establish that, if you're at a program that doesn't have one already established? I think that's a kind of a good segue. We can kind of talk about that.
Well, I'll just add one other thing to that and then hear from others. There's no perfect one way, or I don't know of any departments I've talked to where we do it the same. Our education leadership said we're going to start having faculty development series, and that could be a lecture, that could be a simulation. So it was more kind of stepping up and volunteering to create something, and then having that be one of the things that faculty can check off their box as far as their education requirement for the year. I will say this: what I continue to learn with faculty simulations, faculty don't really like being in simulation. And I think because many of them didn't necessarily train, or some of them, I shouldn't say, many or all, didn't train being in simulation. And so there is a lot of that pushback. Do I really need to be in a sim? And I think all of those learner challenges that we've thought about, feeling like you're on stage, worrying about how your peers are going to, think of you if in the sim, feeling that you're being observed and evaluated, which you are, no matter what type of simulation it is. So they're really not used to being in OSCEs. They're not used to being in sims. So that to me is always the biggest challenge. Maybe some of the medical students I work with, they're in sim from day one. It's like, oh, another OSCE, another sim, like, let's go. So I think that's a huge challenge. Yeah.
So I'll tag on to that, Danny. That's a great point. And I think when you're dealing with a learner group that doesn't experience simulation all the time, the pre-brief that we talk about for our residents, and we talk about in emergency medicine, but often kind of gets abbreviated the more times your residents have done sim, that pre-brief becomes super important because I introduce it as this: we've got the Vegas rule, what happens in sim stays in sim. And that at least puts my faculty a little bit at ease, because at Rush, we have, in the emergency department, every faculty has to go through sim every year. And it's a really neat opportunity to be able to try out some new things. And I've even put them through faculty-based high fidelity simulation where I am their nurse and they are a group of doctors caring for this patient. And I agree, they don't feel like they necessarily need to be in sim. But then when you make the patient that they're doing a conscious sedation on crash, and all of a sudden they're like, oh, so the sat's dropping, let me get a bag. Oh, let me do this next, can you hang some fluids? All of a sudden, like, their doctor brain turns on. And if you get that moment of urgency in a sim, if I have that in my simulations, I'm like, that worked. I don't care how much they were joking about making the most junior faculty person lead the thing at the beginning, as long as they focused their attention on solving the problem at hand when that happened. I really feel like it was a successful sim.
Yeah, I would echo some of the sentiment, especially if it's outside of your peer group. So, for example, having done some simulations for the dental school, outpatient dentist office, primary care office, there's a extremely high level of intimidation sometimes. These strangers are coming in here, putting these people in a tough situation. So sometimes I've gone even to the extreme of literally telling them what the case is exactly going to be, just to sort of make the first simulation be like the most easy softball down the middle, so that they kind of like get their juices flowing and realize that we're not here to humiliate them and intimidate them and those kinds of things. And you can say that and try to have the most nice pre-brief, but people aren't going to believe it until they feel it or see it. So sometimes really, really using the kid gloves, walking them through the process, trying to make people feel light on their feet. And then it's amazing once you kind of have that connection, how much easier it is to kind of do the follow, additional simulations. And then, a lot of them don't even really know the effectiveness of it because they've never experienced it. So sometimes they'll just say, just come in and, do a scenario. Like they don't even know what they don't know about sim and how effective and how cool it can be. So sometimes making sure that you have a very clear goals and objectives as to what you want to accomplish, and then just sort of using the deliberate practice approach. They'll start off, okay, like this scenario today is just going to be a dental emergency. Someone got a little bit too much sleepy gas. You got to bag them and get the AED on them. That's the whole goal for today. Just essentially like a latent safety threat walk through the process of like, do you know where the equipment is? Do you know how to put it on? Do you know how to get the patient on the floor until EMS shows up for 10 minutes, right? And again, if you get them through it, they do okay. You give them a nice little high level debrief, let them do it again, let them do it again. By the end of the day, they're like, this is great. I love this training. This is the best training I've ever had. And a lot of it is just really dependent on that upfront pre-brief done the right way. So I would say, yeah, critically important, especially outside of, brick and mortar, classic GME learner group set.
Yeah, fantastic. Thanks everyone for all the great kind of points. So kind of what I'm hearing is it seems like sometimes things fall in your lap a little bit. Maybe that's not your area of expertise, but kind of making sure you're really well attuned to the needs, the goals, and well prepared for these simulations that are outside our normal purview. And then in terms of faculty or other learner groups that don't necessarily do simulation all the time, sounds like a very solid pre-brief, very important, kind of breaking it down to very simple objectives that are attainable for groups that are not used to it. Definitely some great lessons. Dr. Koboldt, I don't know if you have any other additional thoughts, points, any lessons that you want to share with the group?
Yeah, I was just going to echo a few things that have already been mentioned. I think, as especially those as simulation directors that have done it for a few years, you kind of get into a rhythm of like, whether it's resident sim or medical student sim, where it's just kind of like, okay, this month we're on this topic, and like, you kind of know what's coming, or you have a bank of cases you're working from. And then when you're branching out to something new, it is like, double the amount of work, at least of what you're used to, because you're used to like, okay, I already have this kind of plug and play. This is the case. Everything else is the same, and I know who's going to come. And maybe some of the instructors or the faculty are different, but I know how the day is going to go. And then when you're doing a new modality or a new location, there's like, there's stuff that you don't know is going to go wrong, or there's just things will either unexpectedly work or unexpectedly be a challenge. And I really liked your point of like, when you do this, try to find something that you enjoy doing, because you're going to spend more time doing it, or if it's going well, you may end up doing more and more of it in the future. We had a similar thing where we did like a mass casualty disaster type thing off campus, which was really cool. And so then afterwards, people were like, "Oh yeah, here's another disaster or mass casualty thing." And I'm like, I'm not a mass casualty disaster. I'm like, I'm not EMS. This isn't actually my thing. I mean, it was fun, but it's not my thing. So stop sending me emails about terrible disasters, please. Or they're like, cool, yeah, let's do this like every month or something. You're like, that took 6 months to plan. Like, all right, how about once a year, maybe twice, we'll see. But having having it be something that you do enjoy doing, like, I've been kind of getting into the real tech heavy side of things with some of this VR and AR, and as my co-panelist can attest, I was testing something out before we even started, and it was not working properly. So, especially when it's some of the newer, a newer technology or a new modality, it is going to be frustrating. And so having it be something you enjoy kind of makes that a little more bearable. Because, I love virtual reality and augmented reality, mixed reality stuff. And so when I'm fighting with the headsets, or I suddenly have to charge a dozen things and find 900 cables to, like, I got, here we go, here's a whole bunch, my whole life is all these cables and whatnot. At least I like doing it, and it helps me, rationalize why I own so many like VR headsets and games and stuff to myself and my wife, but it makes it a lot easier when you're like, oh God, this is 4 times as much time commitment to get this to go. to test it and to go there and test the Wi-Fi and stuff. So it's got to be something that you think at the end it's potentially going to be worthwhile. Otherwise, you may just be torturing yourself. And doing it right is good. Like, choosing a giant project that you've never done of something that you've never done, and then when it doesn't go well or isn't of high quality, then yeah, it can sometimes reflect poorly upon the quality of your other work. You're like, no, like we're killing it at regular sim, like we have high quality sim, we're just trying something new here. It's not that the sim, all the things are bad. It's just, you got to try new things, and sometimes it doesn't go as planned. So I just want to echo those points from my co-panelists that they were great.
Awesome. Yeah, and a couple follow-up questions on that. It seems like there's some question about how do you pre-brief VR, and then I'm actually curious to see how have you kind of integrated it into simulation, kind of just because it is a novel field and something that most of us probably are not very experienced in. So hoping you could speak a couple minutes on that.
Sure, absolutely. It is it kind of depends on what you're doing. Obviously, two people can't wear one headset, right? So you can't be like in the headset next to them. It kind of depends on the modality. I've done some different things where we've some of the modalities that we have have a in the software itself, it'll have like an orientation to it. It'll say like, press this button to do this, or like use your voice to say this, or they'll be like, here's where stuff will come up. So some of them have some things built in. Another thing that we've done when we were going to roll this out or do some of this remotely is that during our regular conference time, I was able to screen share like what it looked like on the in 2D, at least on a computer. So I could tell them like, okay, when you put the headset on, it's going to look like this. You're going to have like we're doing an ACLS simulator from Health Scholars, and you're running a virtual team of computer players and your team leader. So I'm like, okay, everybody has a name. It's going to look like this. They're going to talk to you. One of these people never does what you want them to do. That's okay. Sort of setting expectations, and so here's how it's going to run. The other thing I'll do is, try to have good support on the day where we're doing simulation, because usually it's when I put this into our sim day, I put it in our regular sim day just as a station, and I will make sure that I have good faculty support or experienced people running like our other cases or whatever procedure we're also doing. So I'm not having to worry about what's going on in the other room and, keeping the flow going. And instead I can focus like on the station where it's like, okay, I gotta be here doing it. Our sim center does have some, they have their tech point person on their side too. And so they'll often help me be sort of tech support while people are in these simulations to kind of help them. I do tend to put everybody in the same room, but spread out. So we'll use a big room, and then we'll have about four headsets or so running at a time, sometimes more if possible, but around that many, just so I can kind of see what's going on and help people while things are going. But it does help, of course, preparation helps and pre-briefing helps. Also, the fact that we've done some other stuff in the past, like just game-based stuff, like team-based games, like defuse a bomb in VR, like this game called Keep Talking and Nobody Explodes. It's also in 2D, but it's really cool in VR. And so we'll do that just like as a mini station sometimes in sim, and that kind of gets people used to the ergonomics. Like, okay, how do I put the headset on? How do I use the controllers? What do I do? So they're not like, oh, I've never done this before, and they're overwhelmed by, like, how am I supposed to stand, or I'm going to fall over or something, like it helps give them some VR legs, and then you spend less time doing the orientation thing. To the point of like, how do we integrate it into our curriculum? It's somewhat dictated by what I can do. The types of things that we've used VR for so far have been a mixture of some standalone VR and some like team-based VR. So there are some out there, and also kind of what I can get my hands on, because some of this technology is very expensive or subscription-based, and so the pandemic was sort of a double-edged sword because some of the companies released like, oh, we're going to push out a demo case for some of these things or something for COVID or something and for free. So I was able to, or you could apply for a grant for training for things. So, for example, like SimX, who I think is probably the best simulation company for emergency medicine because it's founded and run by emergency physicians. They put a free case out there that was like, one thing was like donning PPE and the other one was like a COVID person comes in with COVID-like symptoms. And they have some different outcomes in there. And it was multiplayer. So an instructor would run it and you had 3 people in the same scenario together, which is kind of cool. So, I mean, it was $0. It was the right price. So, it was a good thing to get people into there because especially in the early days of COVID where there was a lot of concern about it or worry about how are you going to put on PPE or how do I evaluate these people that had it. Or it also helped because like our medical students got banned from seeing anybody with a respiratory complaint or just weren't in the ER. And so I'm like, well, this is as close as I could get you kind of close to seeing somebody, by doing this. The other types of since we're doing most of the stuff that I'm doing now runs standalone on like one of these Oculus Quest standalone headsets, and that makes things so much easier because you're not having to run on the computer. It's like you put the headset on, and especially if they've used it before, it's very intuitive, and then it's almost like mobile gaming. But the having it standalone makes the setup time a lot easier, and a lot of companies are going to it, and the headsets are cheaper. A couple the scenarios we have a success with is actually where it's a 1-player scenario with non-player characters that they're with them, and then kind of grades them on it. But the instructor and the grading and stuff is sort of built into the software, so you're not having to try to figure out what they're doing and evaluate them as it's going. It like feeds out a report, but also gives you the opportunity to do it asynchronously if you have to. Like you could check it out to somebody or they could do it remotely. Like I'm not about trying to add workload to busy residents that outside of sim time, but if conference is canceled and the sim center is closed, like what else can you do? Here's another modality that I can check out a headset to you, sterilize it, check it out to somebody and say, okay, let's do this case. And then I can see if they've done it and give them conference credit for doing it.
Great. And then really quick follow-up, it sounds like for these cases that were free, it's you still have to own your own headset though. Everything is headset based and VR with headset based.
That's a great question. I mean, for most true virtual reality things, it does run on a headset. Some of them during this time, like let's see, health Oxford Medical Sim and Health Scholars and SimX, like some of them came out with flat versions of their software too, where you could just run it on a computer. And so we did put the scenarios, like I had that as an option for people where I installed it on a computer in Physician Lounge, or they could install it and download it as long as they had, a decently recent computer. It could run it without having to be like a high-powered, nerdy-looking Alienware laptop like I have to run some of my other headsets. Like you could run it from a decent PC. The having to own a headset is a bit of a barrier, but it's way less of a barrier than it used to. Even in the last 4 or 5 years, it's come down from you need a $1,500 gaming computer and a $700 or $800 headset, and that's one person, right there, to now like this is the Oculus Quest 2 and it's $299 and it's all self-contained and doesn't need a computer. So thankfully it's become more realistic for people to be able to do, or like I have 5 or 6 of these, and then those are the ones that I use when they go through, or that I can check out to somebody if I need to. And so it's not a crazy amount of money, but it definitely is a limiting factor is cost for sure.
Very nice. Well, appreciate you sharing your experience in that realm. We'll kind of shift gears a little bit, hoping to ask the panelists to kind of explore and explain what their impetus and kind of driving factor for these different niches in simulation were.
I mean, some of it is political. Some of it is, local needs, right? So, there's always the mindset, if you're in a place where they don't necessarily fully appreciate or provide the resources you think you need for your department to really demonstrate your worth, and you're afraid that, you know, some administrative bean counter is going to look to your department to cut, you know, trying to make yourself irreplaceable by branching out in many places as possible, so that when somebody decides that they think they want to cut your budget by 20%, you can say, well, hey, I'm helping the dental school, I'm helping the family medicine practice, I'm helping this, I'm helping that, I'm doing disaster, I'm working with EMS. And then you can get those people to advocate for you. That's just more voices to sort of help you further educate and further identify yourself as somebody who is more important than someone who just plays with dolls in the sim center, right? And so for me, that was a good lesson learned from one of my early mentors administratively, that's paid off dividends. That's helped us expand our sim center several times, helped us get more tech support, more equipment when we need it, and then potentially even opens up, you know, a lot of great relationships and grant funding and stuff like that, where you can look for pockets of money and pockets of support outside the traditional areas where you normally would for simulation. So that's one major one for me that I'm happy to share.
I would echo the driving factor of need and opportunity. So the opportunity came up for me to kind of enter into the standardized patient space when the cases needed to be rewritten and they needed someone to do it at Rush. And I said, oh, well, I have this recent training and could I use it for this? And that role has grown now to having, you know, multiple OSCEs in every clerkship during the M3 year that now are like evolving, that they've canceled step 2 CS. So every year I feel like I'm revising them significantly based on student feedback, based on faculty feedback, learning about validation trials and different ways to implement standardized patient-based cases. So it's been like a nice trajectory of learning for me, and also constantly refining the actual exam and the actual assessments that I've built. And that opens additional doors as I've become more experienced with standardized patient-based cases. People have asked me for different types of things. And it helps you as you become more experienced to recognize an inappropriate request or a request that maybe needs to be modified before you open it up for prime time as a standardized patient-based case. You can't necessarily set your learner up for failure on purpose in a standardized patient-based case. It's not how it's supposed to go, but someone with little knowledge of SP-based cases may not understand that that's, you know, doesn't allow for psychological safety. And so those are the types of things that you can use your experience to help guide those less experienced to make the things that need to happen. Now, there's a lot of things that don't actually need a highly trained, highly expensive, depending on where you are, standardized patient. And you know, I've learned in the residency realm, if I'm trying to teach my residents how to talk to a patient about an incidentally found lung nodule, maybe I just need a faculty member who's delivered that news 400 times and can interact with the resident as if they're a patient. And so that's the innovation that we've used in our residency to cut costs down. Not that I recommend it for any sort of high stakes assessment, because we certainly use standardized patients for those in the medical students, but for residents that are just practicing conversations, we definitely use faculty members that have all that experience that the faculty do have to draw on and kind of help the residents practice that conversation. So.
I think for me, I was probably pulled into sim like many of the folks on the call, like the mannequin-based simulation resuscitations, especially as a toxicologist, you know, opioid, overdose, cocaine, and so then I started working with SPs for the medical school as far as standardized nurses, family members to deliver bad news, adverse event, and then branched out where thinking as a toxicologist with one of the lead researchers on buprenorphine, like, why aren't folks doing this in the emergency department? Well, because they don't feel comfortable with the medication and they don't feel comfortable having conversations with patients, and there's issues of stigma. And, we kind of gave a lecture and sent out a document, and this people are still just not adhering to that practice. So throwing very experienced emergency medicine physicians into an OSCE room where they walk in and the patient is like, WTF, screaming at them, where's my pain medication? And saying, your goal is to screen them for bupe and to also have a conversation about their substance use disorder and nothing else. No physical exam, vitals are on the door sheet. Like, it's super challenging, but for me it was rewarding, and I saw it was rewarding because I saw it was really fun and exciting for them to practice like different language and methods, and then to get debriefing and feedback from some of our addiction medicine folks and some emergency medicine people, and have a conversation like, oh wow, I never knew I could use bupe for this. I never knew that this language is something I can use tomorrow in the emergency department. And so that to me was really rewarding. Most faculty, even if they're resistant, they're comfortable coming in and playing with fiber optic scope or doing like a team-based resuscitation. But I think as we get further away from our training, we're rarely evaluated on our communication patient interaction skills, and it's hard to do that. I think VR is a great place, and if it, I think could be an opportunity to do the same patient interaction communication based simulations. So
Yeah, go ahead.
Oh, no, I was going to say, I appreciate all of what has been said. And I think it's very interesting. What kind of popped to my head as everyone was speaking is the need to balance, to Rami's point, the politics. And a lot of it is, where is the opportunity and how can you branch out based on what the need is or what's being asked of you? And then, balance with what are you excited about? And then how can you do more SIM in that area, which Danny's is such a good example of, because being a clinical toxicologist and a SIM person, I think it's such a cool thing. You've melded your two passions and made this really substantial initiative out of it. So I think how I kind of have fallen into doing more and more has been saying yes, and maybe yes, but I'll do it my way or with my expertise. And then we'll work together to do something that makes sense very deliberately. And then, again, the counterbalance of that being, I've also gotten to a point where I have the social capital to also say no, because sometimes it doesn't need to be a SIM. And if I could tell you the list of things that, our hospital system comes to me with to say, let's fix it with SIM. And it's like, no, you need a policy. Sometimes the answer is not SIM. And it took me a long time to be more confident and not feel like, because you always could SIM it, but just get a little bit more comfortable that I wasn't going to miss an opportunity to continue to grow everyone's awareness of SIM and the ways that you could use SIM, and SIM could be embedded in everything. But that's, I think, where the fun and the magic a little bit happens, of thinking, what I'm excited about, and then how can I meld it with what the need is, and then do it bigger the next time and even bigger the next time, and kind of export it or do it differently, different departments, different things like that.
Yeah, absolutely. So it seems like kind of what I'm hearing from the group is that it definitely often is filling a need that is presented to you, but then trying to figure out how to integrate into something that you are passionate about. And I kind of lead that into the next question in terms of what barriers did you experience in when branching out from the normal kind of residency run simulation? I think especially towards when there's not a need that's asked of you, but when you are actually hoping to bring something that you're passionate about, how do you kind of overcome those barriers, whether they be financial or political or kind of time-based? I'm sure there's definitely more barriers than when someone brings a problem to you to solve. I guess Dr. Lugassy, in terms of your buprenorphine kind of simulation, it seems like that, I don't know if that was something that was presented to you as an opportunity, or if more it was something that was built out of your own passion.
it was definitely something that I volunteered to do. I would say just some quick barriers in working with standardized patients. That I think most of us who've been in SIM, we could just jump into behind a Laerdal 3G right now and run a case. and have a fun time and have a great educational event and debriefing on our own. It's a big difference to sit there with an actor who maybe has no experience with buprenorphine, opiate use disorder, and taking them through a journey of what it's like to be this person. Then how do you respond if A, then B, coaching them. A lot of time and effort goes into that, where most of us would write a case, maybe write a flow of how the vitals are going to go or something. So, it's a challenge, maybe not a barrier, but still rewarding. A barrier is cost. SPs, it's still a cost. And so you have to, leverage any kind of political capital you have with vice chairs of education, with other people who might be doing research, who have an education budget that could build in. So I think that's really something that is tough and is just easier said than done. Last thing, maybe I'll say it, that a mentor said to me that I'm trying to do even better at with all aspects is have some champions who are going to also be involved. I think as EM physicians, we're also like really self-sufficient. We can write the cases, do it on our own, manage it. But having a few people who are excited and involved, they spread the word. And it's like, oh, it's not just Danny Sim, but it's Phil, and it's this person, and it's that person, and they then can spread the word and really build kind of that interest. I think that could go regardless of what kind of new or innovative simulation you're looking to.
Thank you for sharing that. And I was going to add about standardized patients. I absolutely agree. The detail that is required to help someone that doesn't have a medical background get to a point where they can express themselves as a patient is very very detailed. And you have to answer. I mean, our standardized patient case, I think the cases are about 15 pages long, including our gold standard note, including our rubric, including the social determinants of health of the patient, so that they know and have, out of 21 cases, we have on purpose varied social determinants of health, on purpose varied occupations and races and backgrounds. And the really great thing about that is you determine all of it. And the negative is that you have to know what to put. And I've been lucky to have the help of a very experienced standardized patient in an administrative role within the medical college that has been helping make sure the cases are robust enough for the standardized patients that need them. The other thing that I was going to add about standardized patients is that if you're getting into that field, just think about all of the different ways you can use standardized patients productively to teach. So our standardized patients evaluate physical exam skills. They also give written feedback about mannerisms and specific examples of behaviors and statements to the students, so that then they can, it's like a, when you said this, I felt this type of statement. And those, as I'm helping students that are doing poorly understand what's going wrong, those statements are so helpful to the students themselves to get better. And that's the type of feedback that you should know standardized patients can give, so that you ask them to give it. So if you involve a standardized patient in a sim, in the debrief, having them give their perspective is such an important part of the debrief, to say, how did you feel when this conversation was happening? Because that type of information can really help your learner. I can tell them how I thought the standardized patient felt, but the standardized patient has feelings from within that situation that they have been trained to express to the learner afterwards. And many of them, not all of them, but many of them have been trained to express that. And so be aware that that's a possibility and take full advantage of it, because that's part of the package that you're investing in.
Great. Anyone else have any other thoughts or comments they wanted to make?
Yeah, just briefly, I think it's probably the most challenging question you've asked, especially when you see a need or you see an opportunity to do sim and maybe people are not as enthused. I mean, one example I can share is when the whole COVID thing broke out and we had to change the protocol for how to run a code, sort of covering the face of the patient, focusing on compressions only and modifying, the approach with equipment on eye gel versus intubating and having, cameras and the whole thing. Originally part of our administration was like, just have people watch send a PowerPoint and like a sheet. And I was like, people are literally going to die. So literally I had to say like, we have to do in situ. It's like, I don't care if I have to volunteer my time and whatever, like the only way that people are going to really get this to sink through their head when they already have their muscle memory of how they run a code is us, being a little bit disruptive and really sort of making them feel the difference of what they normally do. And, sometimes you have to take the approach and say, like, do you think that people are going to learn this major deviation from their norm by just looking at a PowerPoint versus doing something really truly immersive and then having, expert feedback with faculty. And then when you kind of say it in a different way, when you're not saying the word sim, they're like, okay, I get it. And then you kind of just, again, have to just snowball, get a couple of units to say, this was the best training we ever had. And then next thing you know, you're kind of doing the thing that people thought was not even on their radar. So again, just one example.
Yeah, absolutely. Get some buy-in. Great. Well, I really appreciate everyone kind of answering all of those questions. I'm going to open it up to the group to see if anybody in the audience has any questions for our panelists. Feel free to unmute yourself and ask them if you have any, or feel free to use the chat. If not, I'll pose one more questions in the last kind of few minutes to wrap things up. I'm hoping you guys can kind of, it seems like a lot of the experience that you've had kind of has come over the years, and your many years of experience. I'm hoping to kind of have you think back to the beginning of your career and how you kind of, is there any good advice, the best advice that you guys have for those maybe even starting out in their career who don't necessarily have the buy-in or don't have the support of the, as much of the support of the admin, kind of just starting their career that you can kind of give?
I think great advice starting out in sim is just to really try to wrap your head around what sim is and how much more sim is than what we used to think that term defined, and kind of think about what else you're excited about and how you can meld your worlds. And then also do a lot of saying yes to opportunities and figuring out what modality or what deliberate implementation of sim makes the most sense to get it done. And it may be a high fidelity case, but it may be a case run once or twice, and you look for areas of opportunity, but it doesn't necessarily have to be 100% of all of the staff in one place, like many, I think, leadership often thinks of, because I think the recognition that a lot of people that don't do sim also still only see sim in the box of high fidelity and procedure sim. It's important. So I would just say to be very, conscious and aware and get as much exposure to sim and other realms as you can to know kind of what excites you the most and how you can use it.
Along with the exposure in other areas, I would say seeking out formal organized training programs if there's something that you're interested in. I know there was a group that put on like a really cool telesim conference. There's also like at UIC, I went to the standardized patient-based training certificate program, and that's where my initial experience and understanding of standardized patient-based sim came from. And so if you're embarking on a new program, ask around, ask the people that are here, ask the folks in the Sim Academy, where should I go for this type of training? Somebody will know, and they'll hook you up with somebody who's done it for 10 years that can basically give you a crash course in an hour. Not that that's the recommended way to get it, but just give you some of the resources that can help you be successful with your first couple of steps. Because if those are missteps, it can be discouraging. It can, like Tim was saying earlier, but I'm doing so much great sim over there. It's just at this moment, this particular thing that didn't go well is now the thing you're focused on. So try and make those first couple steps successful if you can by investing in some training programs.
Yeah, I agree with that, Sarah, for sure. I mean, getting or at least getting involved and getting to see how other people are actually doing sim too. Like, because people have, conferences are cool, IMSH is fun, like people talk about sim, but like actually seeing other people do sim, or if you take one of these sim training courses, like they put you into the sims, and so you see how they're doing things operationally, can be helpful. Or one thing that was fun is I did guest invited other people to come do sim with us. So Sarah came down, right, and did sim with us, and did some cool like resuscitive hysterotomy and postpartum sim, and then you steal their cases, and then you still use them later, so boom, now you have another case in your case bank. But it's nice to see other people there. Or the other thing I like to do is partner with people that are like content experts in this field or in your department, or when that person comes with their pet peeve about like, oh, the residents always do this thing wrong, or the ultrasound director is like, they need to, you're like, cool, great, yeah, we'll do a sim on that. You can come and be the content expert, and I'll help run the case, I'll set it up, and you can help lead the debrief on how the case went, or the review, and give them then the pointers based on their feedback there. So then I don't have to go try to become an expert in everything that I'm in every single sim case that I'm doing. Like, it's one of the things I learned from going to one of the sim training courses, is like, they have these people that are like, not even hardcore medical, but they're sim experts, and they do such, you realize how much better they are at this than you are at like listening for key phrases that people are saying and the language they're using, and keeping track of that, and then bringing it up in debrief, like, Tim, I saw that you rolled your eyes 4 times in the case. Tell me about that. And you're like, oh no, like they busted me. But like having specific examples. So I think the training thing can be great from a just seeing things in a networking perspective, but even just locally, like when you're getting feedback or people are saying, oh, we need to do sim on something, like being like, cool, let's partner on this, and you can come help me do it, because you obviously have something that you want to accomplish with this.
I would say quickly surround yourself with people who are smarter than you whenever possible. So it kind of echoes the same thing about going and seeing how different people do different things. If you're going to go build a sim center, talk to 10 people who built a sim center and ask them all the mistakes they make that they wouldn't do again, so you don't make those mistakes. If you want a career where you're producing scholarship, go out of your way to network, get involved in small projects here and there, ask to be middle author. It's okay to be a little bit aggressive. Most sim people are pretty accommodating and nice. And next thing you know is you accomplish little goals here and there. Yeah, I'll write the intro for this paper. You'll snowball, and then people will look at your productivity and just ask, like, how can you be on, how are you producing so much? You got to find the people that are producing and try to get a way to get in there. And, everyone's looking for someone who's willing to do the work. So the more you're willing to do that, the more you're going to find yourself on more projects, to the point where you probably have to start turning away stuff. So that's a good problem to have for most people.
Fantastic. Definitely great advice all around. If anyone else has any questions, definitely feel free to ask them or put them in the chat. Dr. Bentley put some, great advice in there. Collaborate widely, share, and pick a lot of brains. It's sharing and not stealing, right? We're working kind of all as a group. So definitely speak up if you have any questions. Otherwise, I want to thank everybody for joining us, and for our great panelists for all of their advice and experience, and kind of sharing their stories and their niche areas of niches as well. Okay. All right. Well, thank you for everyone for coming. Hopefully everyone learned some great points. I know I did. Appreciate all the panelists for kind of sharing all their experience.
Thanks, Dr. Hughes, for moderating.
Of course. Yes.
Great job.
Good to see everybody.
Yep. Thank you, Michelle.
Thanks,
Yep.
everybody.
Thank you.